This podcast is sponsored by Orchid Live. Orchid Live is a specialist occupational health software used by a number of SOM members to run every aspect of their occupational health operations. They hold healthcare records for over 1 million UK workers and work with both in-house OH teams and OH providers. You can find out more at orchidlive.com. Hello and welcome to the SOM Podcast. I'm Steve Randall, and this episode is one of a monthly series to help you as an occupational health professional with your CPD, as we invite specialists to share an overview of some of the topics you've told us you'd like to find out more about.
I'm Jo Feary. I'm a respiratory consultant specialising in occupational lung disease. I'm also a researcher at Imperial College London, and I'm clinical lead of what we call the Lungs at Work service, which is an NHS service which is run out of the Royal Brompton Hospital in London.
Well, Jo, welcome to the SOM Podcast. How common would you say are respiratory conditions related to the workplace?
Yeah, it's a tricky one to answer, really. So there are lots of different diseases that are caused by breathing in hazardous materials in the workplace. One of the ones that we know about is occupational asthma. And some of the studies have suggested that around 1 in 6 cases of asthma may be attributable to exposures in the workplace. Asthma is a very common condition, which suggests that there are going to be many cases of occupational asthma in the UK and obviously abroad as well. Another condition is silicosis, which I think we'll talk about in a bit more detail, and that's through breathing in respirable crystalline silica. Now, previous data suggests that probably 600,000 workers were breathing in silica in the UK, but that's really old data, and at the moment we don't really have a good idea how many people may be at risk. But I think it's fair to say that there are going to be several thousand people who may be at risk of getting silicosis.
Wow. So, I mean, this is a big topic and one that OH professionals listening to this are highly likely to come across during their work. We'll talk specifically about artificial stone silicosis in a moment, but just on a more sort of general level, traditional forms of silicosis versus artificial stone silicosis, I mean, what are the sort of key differences there?
Yeah, so silicosis has been around for thousands of years. It's one of the most ancient occupational lung diseases. And we know that it's caused by breathing in respirable or crystalline silica, or RCS, and that RCS is going to be invisible to the naked eye. So people often don't realise how harmful it is because they don't actually see it. It causes hardening and stiffening of the lungs, and it's unfortunately an untreatable lung condition. The key thing is how much silica you're breathing in, and that will determine your risk of getting silicosis. So natural stones like marble contain less than 5% silica. Granite contains around 30% silica. And then you have substances like sandstone, which contain 70% silica, so really quite high. What has emerged in the last 20 years or so is a form of artificial stone, and that's used primarily to make kitchen worktops, and it contains over and above 90% silica, which means that when it's cut and polished, if you're not adequately protected, you're going to be breathing in a huge amount of RCS, which means your risk of silicosis is going to go up dramatically.
This is obviously a big deal as more and more building goes on. Obviously, sustainability is a big issue in the building trade, for example. So, they have looked for alternatives to using natural products, but the risks that come with these artificial products is clear from those stats.
Yeah, so there's a number of factors really about artificial stones. So one of the things is it's got very high RCS content. Another is that it's very easy to work with. So we used to think about the traditional stonemasons. They're very highly specialised. They have a craft. They've learned how to cut natural stone and shape it into beautiful ornaments and buildings and things. Artificial stone is very easy to process, and it's primarily used for kitchen worktops because it's really durable, it's stain resistant, it's scratch resistant. You can make it in lots of different colours so it can match your interior, and it's cheap. And it's cheap because it's easy to process. So you don't need to avoid those natural lines and faults in the material. And so people have set up workplaces where it's being cut and polished without appropriate engineering controls and hierarchy of controls, which means that not only is it got very high silica content, but there's also no use of water suppression, there's inadequate respiratory protection, there's no engineering controls. And that further increases the amount of RCS people are breathing in. So it's causing a different form of silicosis from that we are historically used to.
Would an OH professional see different symptoms?
So the thing about silicosis is that in the first instance, you have no symptoms. So until you have really quite significant disease, you're not going to have any of the sort of cough, breathlessness, chest tightness, fatigue, weight loss that people with silicosis can report. With forms of artificial stone silicosis, you will still develop the same symptoms that you would have with silicosis from natural stone. However, the difference is the group of people it's affecting. So we've all been taught that silicosis comes on 10, 15, 20 years or more after exposure. So you need, several years of exposure before you get symptoms. With artificial stone silicosis, it's coming on much more rapidly. So it can come on after, on average, around 10 years of exposure, but some of my patients have got it after only a couple of years of exposure. And therefore, it's affecting a much younger workforce. So many patients are in their 20s and 30s. Because of the nature of the workshops that many are working in, a high proportion of them are migrant workers, and so may not have access to occupational health in the same way, just by nature of the industries in which they're working, the workshops in which they're working.
And this obviously brings us to health surveillance and diagnosis. I mean, what medical surveillance or screening protocols are in place and what are recommended for workers who may be exposed to artificial stone dust?
So the current HSE health surveillance is for anyone where there is a residual risk of RCS exposure. And that currently states that you should consider a baseline chest x-ray, regular spirometry and questionnaires, and then after 15 years of exposure, a chest x-ray, and then chest x-rays every 3 years thereafter. The slight problem with that is that it's not necessarily going to pick up these cases of artificial stone silicosis because they happen much earlier. So it's a form of accelerated silicosis because it happens prior to 10 years of exposure. And so the guidelines were rewritten last year and suggest that if there is a risk of accelerated disease, that those chest x-rays start much sooner. But it doesn't actually specify when that time frame should begin. And I think there are discussions at the moment about how we can be a little bit clearer and give some guidance around when that imaging should start. There's also the issue, of course, that chest x-rays aren't going to pick up early disease and whether we should be thinking about using other forms of imaging, such as those used in Australia and elsewhere. And that would include something like a low-dose CT, which is a sort of scan that we do for people when we're doing lung cancer screening. We really don't understand the scale of the problem in the UK at the moment. So in other countries, like Australia, they've done an active case finding programme and identified over 1,000 cases of artificial stone silicosis in their workers. We don't really know how many people are working in the industry in the UK, and we have around about 40 cases that have been identified in the last 2 years. But really, we don't really know how many more are going to come forward. And we know that the cases that we have at the moment are primarily in workplaces where there is breach of health and safety regulations because of the amount of dry cutting and high exposure levels that are evident there. What we don't know is that whether people who work in well-run, well-maintained factories where there is good health and safety controls will have cases of disease there as well. And that's a question that remains to be answered. It's really important as OH clinicians that people are aware of the issue and know the right questions to ask. And really that is, have you ever worked with artificial stone and have you been dry processing artificial stone? If the answer to those questions are yes, then you just need to have a high index of suspicion that this person's may have silicosis and it may behave in a different way from that they're sort of traditionally used to. And it's just really about asking those probing questions, being a bit of a detective, having a look at the workplaces and doing the sorts of things that all OH advisors and clinicians tend to do.
Yeah, I was going to say, thank goodness that the OH professionals are very good at taking histories and asking those questions about backgrounds, whereas sometimes other health professionals either don't have that kind of mindset or they just don't have the time.
Yeah, exactly. And we're doing a huge amount of education work in hospital settings for respiratory clinicians to try and raise the awareness of this condition, because silicosis can look like other respiratory conditions like sarcoidosis. And I've had messages actually from occupational health advisors to say, my stonemason's been diagnosed with sarcoidosis. do you think this could actually be silicosis? And they were absolutely right when we probed a bit further. So it's really important that, education is widespread and not just covering people who work under the occupational health umbrella, but also those who are working in primary and secondary care. A lot of these patients will present to their GP in the first instance. So we've got a lot of work to do about spreading the word.
Yeah, I mean, this is a big topic, and obviously we only scratch the surface in these mini CPD episodes that we do, but I'm sure you've given our listeners a lot of food for thought there and things that they will do more research on. They'll want to find out more about the risks and to brush up on, what they can do to help mitigate them. How can people find out more about you and what you do, Jo?
There are lots of things in the literature, and you can find online about artificial stone silicosis because it's been described in 12 different countries now around the globe. We have a departmental website called lungsatwork.org.uk, and we've got resources on there to provide more information about silicosis in general and artificial stone silicosis. The other thing is that our clinical service is an NHS service. It's free for businesses. So you can refer patients on the NHS to see us, and we aim to see them within 6 to 8 weeks. And we also have an email address that you can send inquiries to. So if you've got a case you're not sure about, if you've got a workplace that you're a bit worried you may have cases at, if you want to understand a bit more about health surveillance, do just get in contact with us. We're here to try and support the occupational health community, and we're available at any time. So just reach out, and our email addresses are on our website.
Jo, it's been fantastic speaking to you. Thanks so much for sharing more on this topic and hopefully to broaden and grow the awareness of this amongst our OH community.
Thanks very much for having me.
This podcast is sponsored by Orchid Live. Orchid Live is a specialist occupational health software used by a number of SOM members to run every aspect of their occupational health operations. They hold healthcare records for over 1 million UK workers and work with both in-house OH teams and OH providers. You can find out more at orchidlive.com.